Welcome to the Deep Dive. We're your shortcut to really getting under the skin of complex topics. Today, we're jumping into, well, the fascinating, sometimes frustrating world of canine endocrine disorders. We've got some great material here, pulled from a really comprehensive veterinary review the kind vets themselves use. And our mission, for you listening, is pretty simple. Let's decode these often hidden conditions. Let's understand those vague signs, and shed some light on the clever ways vets diagnose and treat them. You'll come away with a much deeper understanding, ready to be a really well-informed partner in your dog's health.
Yeah, and what's genuinely fascinating, I think, and what makes them such a challenge, is that they're often called the great pretenders.
Right.
You see the clinical signs, things like, well, maybe subtle changes in weight or how much water a dog drinks, maybe even their personality.
Blah.
They can be so non-specific.
So they could look like anything, basically.
Exactly. They can easily mimic lots of other, less complicated health issues, which really highlights why vets need a high index of suspicion and a really systematic, precise approach to testing. It's not just seeing a symptom. It's about digging deeper, understanding what could be happening, behind the scenes.
Okay, let's unpack this then. Let's start right at the beginning, the foundation, the canine endocrine system. So picture it like your dog's internal communication network, right? A really sophisticated system of glands all over the body.
Little factories.
Yeah, like tiny factories producing these chemical messengers, hormones, and they secrete them right into the bloodstream. And these aren't just random chemicals, they're the conductors, basically orchestrating almost everything. Energy, growth, stress response, even reproductive cycles. It's pretty incredible how much these small glands control.
And our source material does a great job breaking down the key players. So right at the base of the brain, you've got the pituitary gland.
Master gland.
Kind of, yeah. Think of it as the conductor of this hormone orchestra. It manages growth, milk production, sure, but also keeps the dog hydrated via ADH. And crucially, it tells other glands when to release their hormones. Things like ACTH, TSH. It's this vital bridge between the nervous system and the hormone system. And working right alongside it is the hypothalamus, helping regulate the pituitary itself.
Okay.
Then, moving down, in the neck, you have the thyroid gland. This one produces T4 and T3, hormones that are absolutely fundamental for setting the dog's metabolic rate. Basically, how fast the body uses energy affects nearly every organ.
Got it.
And right near the thyroid, there are 4 tiny parathyroid glands, small but powerful. They secrete parathyroid hormone, PTH, which is critical for balancing calcium and phosphorus. Keeps those levels just right, really quickly adjusting them.
Calcium balance, okay.
Then, deeper in the abdomen, sitting on top of the kidneys, are the adrenal glands. Each one has 2 parts. The outer layer, the cortex, makes steroid hormones. These include mineralocorticoids, like aldosterone, think blood pressure, water balance, and glucocorticoids, like cortisol. Cortisol's huge. Metabolism, blood sugar, stress response, immune function.
That's a lot of jobs for one hormone.
It really is. And the inner part of the adrenal, the medulla, that's where the fight or flight hormones come from.
Yeah.
Epinephrine, norepinephrine, ready for action.
Instant response stuff.
Exactly. Then, near the liver and stomach, we find the pancreas. It secretes insulin and glucagon. These two work together like a seesaw to keep blood sugar levels stable.
Right, the diabetes connection.
Precisely. And finally, the ovaries in females and testes in males, the gonads. They produce the sex hormones, estrogen, progesterone, testosterone for sexual characteristics and reproduction.
Wow, okay. It really does paint a picture of this intricate network. And like you said, the tricky part is an imbalance in any one of these, or their hormones, can cause such varied, vague signs. Makes that initial diagnosis feel like detective work, doesn't it? Often needs those specific tests.
Absolutely. And if we look at the bigger picture, canine endocrinology is a really significant chunk of veterinary practice. Conditions like diabetes, Addison's disease, Cushing's, they're diagnosed pretty frequently, especially as dogs get older. And what's also quite interesting is how many of their signs, and even the underlying problems, look a lot like human endocrine diseases.
I hadn't thought of that parallel.
Yeah, it really underscores that successful diagnosis isn't just, spotting one symptom. It takes a deep understanding of the whole system, a really systematic, precise investigation. You have to know where to look, and just as importantly, why.
Okay, here's where it gets really interesting then. Let's dive into some specific disorders. We have to start with hypoadrenocorticism, right? Addison's disease. That's the ultimate great pretender we talked about.
Yeah.
Just because its signs mimic so many other things, it's actually not super common, mostly dogs, rarely cats.
Right. So let's talk about what's going on inside. The most common type is primary Addison's. This means there's destruction of both adrenal cortices, those outer layers of the adrenal glands.
Both of them.
Both of them. And in most cases, maybe 85–90%, it's thought to be immune-mediated. The dog's own immune system attacks the adrenal glands.
Oh, wow. Okay.
This leads to a combined lack of both mineralocorticoids like aldosterone for salt balance and glucocorticoids like cortisol for stress response. So the body struggles to manage salts, water, leading to dehydration, dangerous heart rhythm issues, and the lack of cortisol causes GI problems, lethargy, low blood sugar.
A double whammy.
Pretty much. Then there's atypical Addisons.
Yeah.
Here, only the cortisol's low initially, so the electrolytes, the salts, might look normal at first. That can really throw you off.
Yeah, I can see that.
And critically, there's iatrogenic Addisons. This can actually be caused by treatments, either drugs used for the opposite condition, Cushing's, or if a dog's on high-dose steroids long-term and they're stopped too quickly.
Oh, so doctors have to be careful tapering steroids.
Absolutely crucial. And less commonly, secondary Addisons, where the pituitary just isn't sending the right signal, ACTH, down to the adrenals.
Okay, so what are owners actually seeing at home? What are the signs?
Oh, that's the thing. They're notoriously vague. Often they come and go waxing and waning, we call it. Happens in maybe 25–43% of cases. Owners often report things like poor appetite, maybe anorexia, just really tired, lethargic. Vomiting is common, general weakness.
Sounds like it could be anything.
Exactly. Weight loss, diarrhea, drinking or peeing more, though that's less common than in other diseases, maybe shaking, sometimes collapse, abdominal pain even. But one really crucial finding for a vet during an exam, a slow heart rate, bradycardia, in a dog that's collapsed or in shock. That's a huge red flag.
Why slow? Shock usually makes the heart race, right?
Normally, yes. But in Addison's, the high potassium level, the hyperkalemia from the lack of aldosterone, directly affects the heart muscle, slowing it down. So, slow heart rate in a shocky dog. Think Addison's. Highly suspicious for hyperkalemia.
Okay, that's a key clue. So, if the signs are so vague, how does a vet even start to figure it out? What are the diagnostic steps?
It's definitely a process. We might start with a screening test to resting cortisol level. If that's above a certain threshold, say 2.0 milli-CGDL, Addison's is pretty much ruled out.
Okay, so that's a good first step.
It is. But a low level by itself doesn't confirm it. Lots of things can cause low cortisol. So we look for those classic lab abnormalities. High potassium, hyperkalemia, low sodium, hyponatremia. That combination is seen in most primary cases. And the sodium-potassium ratio is key. If it's less than 27.1, especially below 20.1, that's highly suggestive of primary Addison's. But remember, normal electrolytes don't rule out the atypical or secondary forms.
Right, the cortisol-only deficiency ones.
Exactly. Another really important clue, especially for vets, is the lack of a stress leukogram. Normally, a sick, stressed dog releases cortisol, which causes predictable changes in their white blood cell counts, neutrophils up, lymphocytes, and eosinophils down.
Okay, the body's normal stress response on a blood test.
Right. So if a dog is clearly sick, but their white cell count looks, well, normal, or doesn't show those stress changes, especially if the lymphocytes are normal or high, that's a big hint. It suggests their cortisol response is missing. Points towards Addison's. We might also see kidney values looking high because of dehydration, maybe high calcium or low blood sugar, especially in secondary cases. Mild anemia, too, sometimes. Imaging can help support the diagnosis. Ultrasound might show small adrenal glands. Chest x-rays might show a small heart because of dehydration. An ECG can show those specific changes from high potassium peaks T waves, funny rhythms.
Okay, lots of potential clues, but what's the definitive test, the one that nails it?
The definitive confirmation, the gold standard, is the ACTH stimulation test. We measure a baseline cortisol level. Then we give an injection of synthetic ACTH, that's the hormone the pituitary normally sends to the adrenals. Then we measure cortisol again an hour later. In a healthy dog, or a dog with other illnesses, the adrenals will respond by producing more cortisol. In a dog with Addison's, the post-ACTH cortisol level will be very low, typically 2 milli-GDL or less. They just can't respond.
Ah, okay, so the adrenals just don't react to the signal. That makes sense. Perfect example of why it's the great pretender those initial signs are so misleading. Now let's flip the coin. Let's talk about hyperadrenocorticism, or Cushing syndrome, the opposite problem, chronic excessive cortisol. And this one's quite common, right? Especially in older dogs.
Yes, much more common than Addison's, usually middle-aged to older dogs. And like Addison's, it comes in different forms. The vast majority, maybe 80–85% of cases, are pituitary-dependent hyperadrenocorticism, PDH. This is usually caused by a tiny benign tumor, an adenoma, in the pituitary glands.
That master gland again.
Yep. This little tumor churns out too much ACTH signal. This tells both adrenal glands to get bigger and pump out way too much cortisol. The other 15–20% are adrenal dependent, ADH. In these cases, there's a tumor in one of the adrenal glands itself, just overproducing cortisol independently. This excess cortisol actually tells the pituitary to stop sending ACTH, so the other normal adrenal gland often shrinks. It atrophies.
Okay, so one big adrenal, one small one.
Typically, yes. And just like Addison's, there's iatrogenic Cushing's, caused by giving too many external steroids over time. Certain breeds seem predisposed to the pituitary form: poodles, dachshunds, boxers, bosters, while the adrenal form is maybe more common in medium to large breeds. But the bottom line is this chronic excess of cortisol just throws the whole body's feedback system out of whack, leading to those widespread signs.
And what are those signs? What do owners typically notice with Cushing's?
They're usually progressive, insidious, and generally similar regardless of the form, because it's all down to too much cortisol. The most frequent signs, the ones owners almost always report, are polydipsia, drinking a lot, and polyuria, peeing a lot. PUPD, we call it.
PUPD. Got it.
Also, polyphagia, increased appetite. That classic pot-bellied look is very common. That's due to fat moving around, the liver getting bigger, and the abdominal muscles getting weak. Skin changes are really common too. Symmetrical hair loss, often not itchy, thin, fragile skin, sometimes dark pigmentation, maybe calcium deposits in the skin called calcinosis cutis, easy bruising, skin infections.
Sounds quite distinctive, those skin changes.
It can be. Also, muscle weakness, lethargy, excessive panting, maybe can't tolerate heat well. Less common, but serious signs can include systemic hypertension, high blood pressure, which can lead to other problems like blood clots, even congestive heart failure, or neurological signs if a pituitary tumor gets large enough to press on the brain, causing blindness or seizures.
Wow. So, okay, that's a long list again. And some of it, like lethargy or drinking more, could just seem like aging. How do vets confirm this one, the diagnostic path for Cushing's?
It's definitely a comprehensive approach. You need to put together the clinical picture, the lab tests, imaging. There's no single perfect test. On routine blood work, vets often see that stress leukogram again, but this time it fits because there is excess cortisol. High neutrophils, low lymphocytes, low eosinophils. A very common finding is a markedly elevated alkaline phosphatase, ALP. There's a specific form of this enzyme induced by steroids. High cholesterol is common too, maybe mild high blood sugar. Interestingly, about 10% of dogs with Cushing's also have full-blown diabetes mellitus concurrently.
Ah, okay. And urine tests.
Urinalysis often shows low urine-specific gravity, meaning the urine is very dilute because the dog is drinking and peeing so much. Protein in the urine is common. And urinary tract infections, UTIs, are super common, sometimes without any obvious signs, so a urine culture is often recommended.
Okay. What about looking inside? Imaging.
Imaging is really crucial, especially abdominal ultrasound. It lets us look directly at the adrenal glands. In pituitary-dependent Cushing's, PDH, we typically see both adrenal glands are enlarged, maybe symmetrically. In adrenal-dependent Cushing's, ADH, we expect to see one large adrenal gland, the one with the tumor, and the other one small or atrophied. Ultrasound can also help look for spread metastasis if it's a malignant adrenal tumor.
So ultrasound helps tell PDH from ADH sometimes.
It's a key piece of the puzzle for differentiation, yes. Chest x-rays are good for checking for metastasis too, or other changes like calcification in the airways. Sometimes we might need advanced imaging like CT or MRI, especially if we suspect a large pituitary tumor, a macroadenoma, or need more detail on adrenal mass.
Okay, so clinical signs, routine labs, imaging. What are the specific confirmatory tests for Cushing's?
Right, the endocrine tests. We have a few main options. The urine cortisol. Creatinine ratio, UCCR, is a good screening test. It's very sensitive, meaning if it's normal, Cushing's is unlikely, but it's not very specific. Lots of other illnesses or stress can make it high. So a high UCCR needs follow-up, ideally collected at home to minimize stress.
Right.
The low-dose dexamethasone suppression test, LDDST, is often considered the test of choice for naturally occurring Cushing's if the dog doesn't have other significant illnesses going on. Basically, we give a small dose of dexamethasone, a steroid, which should tell a normal dog's pituitary to stop producing ACTH, thus lowering cortisol. In most dogs with Cushing's, both PDH and ADH, this suppression doesn't happen properly.
They fail to suppress.
Exactly. Or sometimes with PDH, they might suppress early, then escape suppression later. The downside is other non-adrenal illnesses can sometimes cause a false positive. Then there's the ACTH stimulation test. This one's shorter, simpler. Its sensitivity is a bit lower than LDDST, maybe 80–85%, but it's generally considered more specific, less likely to be positive due to other illnesses. It's often preferred if the dog does have concurrent conditions or if we suspect iatrogenic Cushing's from external steroid use. In naturally occurring Cushing's, we typically see an exaggerated cortisol response to the ACTH injection. Adrenal tumors can sometimes be tricky with this test, though.
Okay, so LDDST and ACTH stim are the main ones for confirming if it's Cushing's. What about telling pituitary versus adrenal apart? You mentioned ultrasound helps.
Yes, ultrasound is key, but we also have differentiating tests. The high-dose dexamethasone suppression test, HDDST, can help. The theory is the higher dose of dexamethasone might be enough to suppress the pituitary tumor in PDH cases, but it won't suppress an independent adrenal tumor. However, some large pituitary tumors might not suppress even on the high dose.
So not foolproof.
Not foolproof. Probably the most direct and expedient way to differentiate is by measuring endogenous plasma ACTH levels. If it's an adrenal tumor, ADH, the tumor is making cortisol on its own, suppressing the pituitary, so the dog's own ACTH level will be low or undetectable. If it's pituitary-dependent, PDH, the pituitary tumor is making excess ACTH, so the level will be normal or often high.
That seems pretty clear-cut. Low ACTH means likely adrenal tumor. Normal high ACTH means likely pituitary.
Generally, yes. It's a very useful differentiator.
Okay, so once you have a diagnosis and know the type, what about treatment and prognosis?
Treatment aims to control that excess cortisol production and manage the clinical signs. For most dogs, especially with PDH, medical management is the mainstay. The drug of choice nowadays is usually trilostane. It works by inhibiting an enzyme needed to make cortisol. It's typically given once or twice a day with food. We monitor its effectiveness using ACTH stimulation tests and adjust the dose. Another older option is mitotane, which actually selectively destroys the cortisol-producing cells in the adrenal cortex. It can be very effective, but requires really careful monitoring to avoid causing Addison's disease as a side effect.
Right, swinging too far the other way.
Yes, exactly. If it's an adrenal tumor, ADH, surgical removal, adrenalectomy of the affected gland is the potentially curative treatment. It's a major surgery, carries risks, but median survival times can be pretty good, over 2 years for carcinomas, though postop mortality can be significant, maybe 14–60%. For pituitary tumors, PDH, surgery, hypophysectomy, to remove the pituitary tumor is possible at highly specialized centers. It can lead to rapid remission, maybe 80% success rate. Radiotherapy is another option, especially for large pituitary tumors causing neurological signs. Newer techniques like CyberKnife or Gamma Knife offer faster treatment courses.
And the prognosis overall?
It varies. For PDH managed medically with trilostane, the median survival is often reported around 2 to 2.5 years, though some studies show longer times, maybe closer to 3 years with specific protocols. For ADH treated surgically, prognosis can be good if removed completely, maybe 1.5 to 4 years. Medical treatment alone for ADH usually offers shorter survival, maybe around a year. Quality of life is often very good with successful management.
Okay, so from too much cortisol, let's shift gears now to hypothyroidism. Too little thyroid hormone. This one's also pretty common, right? And tends to creep up slowly.
Yes, very common, and definitely tends to have an insidious onset. The underlying issue is usually primary hypothyroidism. The thyroid gland itself is failing. The two main reasons for this are either idiopathic thyroid gland atrophy, where the gland just sort of wastes away for unknown reasons, or, more frequently, immune-mediated lymphocytic thyroiditis, where the dog's immune system attacks and destroys the thyroid tissue.
The immune system again. Seems like a common theme.
It really is in endocrinology. Less common causes include congenital problems or issues with the pituitary not sending the TSH signal, secondary hypothyroidism, but primary failure is by far the most common. It typically affects middle-aged dogs. Any breed can get it, but we see it a lot in mixed breeds, golden retrievers, Dobermans, Labs. The core problem is that low levels of thyroid hormones slow down the body's metabolism, impacting pretty much every system and leading to those characteristic signs.
And what are those signs? What should owners look out for?
Again, often vague and non-specific, especially early on. The classic signs relate to that decreased metabolic rate. Lethargy, mental dullness, inactivity, maybe an unwillingness to exercise. Weight gain is common, often without any increase in appetite. Cold intolerance seeking out warm spots.
The slowing down signs.
Exactly. And dermatologic changes are probably the most common reason owners bring their dogs in. You often see bilaterally symmetric non-pruritic alopecia hair loss on both sides of the body, usually the trunk or areas of wear, and typically it doesn't itch. Also, post-clipping alopecia where the hair just doesn't grow back or grows back very slowly after being shaved. The coat might look dry, dull, maybe flaky or greasy, seborrhea. Hyperpigmentation, dark skin, and recurrent skin or ear infections, pyoderma, otitis externa, are also very common.
Okay, so skin and coat problems are a big flag.
a very big flag. Less commonly, you might see neurologic effects like peripheral neuropathies causing weakness or knuckling, sometimes vestibular signs or facial nerve paralysis. A slow heart rate, bradycardia, can occur. Rarely things like megaesophagus or lipid deposits in the eyes. And then there's myxedema coma, which is rare but life-threatening. Profound hypothermia, severe heart rhythm problems, mental decline, thickened, tragic facial expression due to fluid buildup under the skin.
That sounds terrifying. Okay, so again, some vague signs, some more specific, like the skin issues. How do vets confidently diagnose this one, especially considering other things can affect thyroid levels?
Yeah, diagnosis requires a careful, stepwise approach. And importantly, we really should only test dogs where there's a strong clinical suspicion. Just screening random dogs isn't very helpful. Routine blood work might show some supportive hints. Hypercholesterolemia, high cholesterol, is seen in about 75% of cases. Maybe high triglycerides, mildly elevated liver enzymes, or a mild non-regenerative anemia in about a third of dogs. Urinalysis is usually normal, but the crucial thing is considering those factors that influence thyroid tests. This is key to avoid misdiagnosis.
Right, you mentioned medication.
Yes, drugs like prednisone, some NSAIDs, phenobarbital for seizures, they can all artificially lower thyroid hormone levels, especially total T4. Also, non-thyroidal illness, NTI, or euthyroid 6 syndrome. Basically, any significant systemic illness can suppress thyroid hormone production as a protective mechanism. So a sick dog might look hypothyroid on test, but their thyroid gland is actually fine.
So you have to rule out other illnesses first.
Absolutely. Breed makes a difference too. Sighthounds, like greyhounds, naturally have lower T4 levels. Age also plays a role. Levels tend to decrease slightly as dogs get older, and there can just be random day-to-day fluctuations.
Okay, so lots to consider. What are the specific tests then?
We usually start with total T4, TT4. This measures both bound and unbound T4 hormone. It's a good screening test, high sensitivity, 8900%. If the TT4 is well within the normal reference range, hypothyroidism is very unlikely. But a low TT4 alone is not diagnostic because of all those factors we just mentioned.
Right, so if TT4 is low, what's next?
Next step is often measuring free T4, FT4, usually by a method called equilibrium dialysis, FT4 by ED. Free T4 is the biologically active form, and it's less affected by non-thyroidal illness and binding protein changes than TT4. If the FC4 is also low, that strengthens the suspicion. We also measure thyrotropin, TSH, which is a signal from the pituitary telling the thyroid to work. In primary hypothyroidism, thyroid failure, the pituitary should be shouting louder, so TSH is expected to be high in about 2/3 of cases. So the definitive diagnosis is usually based on finding a low TT4 and/or a low FT4 combined with a high TSH. That pattern strongly supports primary hypothyroidism.
What if TSH is normal?
That happens in about a third of cases. If TSH is normal, but TT4 and FT4 are both unequivocally low, and we've carefully ruled out non-thyroidal illness and drug effects, we can still make the diagnosis, especially if the TSH value is maybe in the upper end of its reference range. Sometimes we also test for antithyroglobulin antibodies, TGAA. These indicate that immune-mediated destruction is happening. Finding them increases confidence, but not finding them doesn't rule it out, as they're only present in about half of immune-mediated cases.
Okay, so it's really about putting the TT4, FT4, and TSH results together in the context of the clinical signs and ruling out other factors.
Exactly, it's pattern recognition.
And the treatment, you said it's lifelong.
Yes, lifelong therapy is required. The treatment is supplementation with oral levothyroxine synthetic T4. Standard starting dose is often 0.02 milligeocrams, usually given once daily, though sometimes twice daily dosing is needed if response isn't ideal. Owners typically see improvement in energy levels and mental alertness within a few weeks. Those skin and coat changes, however, can take several months to fully resolve.
Patience is needed for the fur to come back.
Definitely. We monitor therapy by checking thyroid levels, usually about 4 weeks after starting treatment. We measure T4 levels 4 to 6 hours after the pill is given. The target is generally to have the T4 level in the upper end of the normal reference range, or even slightly above, at that peak time. We adjust the dose by about 25% based on those results. Once the dog is stable, we typically recheck every 6 months or so.
What if the dog doesn't seem to improve?
True treatment failure is uncommon if the diagnosis is correct. It's often due to owner compliance issues, missed doses, or sometimes variable absorption of the medication. If the T4 levels are hitting the target range but the clinical signs aren't resolving, we might need to reconsider the diagnosis or look for other concurrent health problems. But overall, the prognosis for hypothyroidism is excellent, with appropriate lifelong treatment and diligent monitoring. dogs can live completely normal, happy lives.
That's great news for such a common condition. Okay, let's switch gears again to another really prevalent one, diabetes mellitus, the issue with glucose and insulin.
Right. Diabetes mellitus is a chronic disorder of carbohydrate metabolism. It boils down to either an absolute lack of insulin production by the pancreas or a relative deficiency where the body cells don't respond properly to the insulin that is there, insulin resistance. It typically affects dogs between 4 and 14 years old, with a peak around 7–10 years. And interestingly, female dogs are affected about twice as often as intact males.
Any idea why females more often?
It's often linked to hormonal influences, particularly progesterone, during the diestrus phase of their cycle, which can induce insulin resistance. This is a key reason why spaying is so important for diabetic management in female dogs. Other causes can include destruction of the insulin-producing islet cells in the pancreas, either immune-mediated like we see in human type 1 diabetes, or secondary to severe or chronic pancreatitis, which damages the pancreas. Risk factors include obesity, those hormonal changes in intact females, history of pancreatitis, concurrent endocrine diseases like Cushing's or hypothyroidism, chronic steroid use, even things like chronic dental disease or infections can contribute to insulin resistance.
Okay. And the basic physiology, what's going wrong?
So without enough effective insulin, glucose can't get from the bloodstream into the body's cells to be used for energy. This leads to hyperglycemia, high blood sugar. When the blood glucose level gets too high, it exceeds the kidney's ability to reabsorb it, all the renal threshold, which is around 180 milli-GDL in dogs. Glucose then spills into the urine, glucosuria. This glucose in the urine acts like an osmotic agent, pulling water out with it. That causes polyuria, excessive urination, which then triggers polydipsia, excessive thirst, to compensate for the water loss.
The classic PUPD again.
Exactly. Meanwhile, because the cells are starved for glucose energy, the body starts breaking down fat and muscle for fuel. This leads to weight loss, even though the dog is often eating more, polyphagia, because its brain thinks it's starving. Insulin resistance complicates things further, where the target cells just don't respond well to insulin signals.
Okay, so those are the main signs. PUPD, weight loss, increased appetite.
Those are the cardinal signs, yes. Usually insidious onset chronic course. Owners might also notice lethargy or weakness. Cataracts develop very commonly and often rapidly in diabetic dogs due to a specific metabolic pathway involving sorbitol in their lenses. They're also prone to chronic or recurring infections, especially skin infections and UTIs. An enlarged liver, hepatomegaly, and panting can also occur. And then there's the severe complication, diabetic ketoacidosis, DKA.
Right, you mentioned that. What does that look like?
DKA is a medical emergency. It happens when the body's fat breakdown goes into overdrive, producing acidic byproducts called ketones. The dog becomes very sick, maybe a sweetish smell to the breath like nail polish remover, profound quietness, reluctance to eat or drink, vomiting, diarrhea, trouble to rapid breathing, severe weakness, even collapse. Owners must contact their vet immediately if they see these signs.
Okay, really critical to recognize DKA. So if an owner suspects diabetes based on the PUPD and weight loss, how is it confirmed?
Diagnosis is usually straightforward. It's suspected based on those classic clinical signs and confirmed by finding persistent hyperglycemia, high blood sugar normal is roughly 75 to 120 milli-GDL, and glucosuria, glucose in the urine, on blood and urine tests. Stress alone can cause temporary hyperglycemia, especially in cats, less so in dogs, but finding glucose in the urine consistently is key. We also often measure serum fructosamine. This protein reflects the average blood glucose control over the preceding 1–3 weeks, so it's much less affected by short-term stress or recent meals. It gives a better picture of the overall control. And as mentioned, checking for UTI with a urine culture is important because they're so common and can make diabetes harder to regulate.
Okay, and once diagnosed, it's all about management and monitoring.
Absolutely. It's a lifelong condition for most dogs. Consistent, regular monitoring is key. This involves vet checkups, periodic blood tests like glucose curves or fructosamine, urine tests, and the owner carefully tracking the dog's weight, appetite, drinking, and urination at home. Insulin dosages almost always need adjustment over time. For glucose monitoring, ideally owners learn to perform home blood glucose monitoring using a portable glucometer. This gives the most accurate picture of how the dog is responding to insulin throughout the day. Continuous glucose monitoring (CGM) systems are becoming more common too. A small sensor placed under the skin provides readings every few minutes for several days, giving fantastic trend data, identifying hidden lows, especially overnight, and reducing the need for frequent needle pricks. Any concerningly low CGM reading should still be confirmed with a blood glucose check.
CGM sound like a game changer.
They really can be for fine-tuning control. Urine ketone monitoring might also be needed, especially if newer drugs like SGLT2 inhibitors were ever considered, though insulin is the mainstay in dogs.
Got it. So what is the standard treatment?
Insulin therapy is required for almost all dogs with diabetes. The usual starting point is an intermediate-acting insulin like NPH or lente-veslin. The typical starting dose is around 0.25 to zero point 0.5 units per kilogram of body weight, given by subcutaneous injection usually twice daily every 12 hours. Most dogs need 2 injections a day, timed to coincide with 2 equal-sized meals, given immediately before the injection. This consistency is vital.
So injections twice a day for life.
Typically, yes. Owners learn to give the injections using very small needles, and most dogs tolerate it very well. The dose and sometimes the type or timing of insulin will be adjusted based on the monitoring results, glucose curves, CGM, fructosamine, clinical signs. Sometimes longer-acting basal insulins like Detamir might be used if control is difficult. As we mentioned, spaying intact females is highly recommended for stable regulation. Dietary management is also crucial. Diets higher in fiber and complex carbohydrates are often preferred, as they help slow glucose absorption. Avoid simple sugars found in many treats. Consistency in diet type and amount is key, and it's vital the dog eats normally before getting insulin to avoid hypoglycemia.
Right, the risk of low blood sugar.
Exactly. Hypoglycemia is a major concern. Owners need to be vigilant for signs like weakness, lethargy, stumbling, muscle tremors, unusual behavior, or seizures. If suspected, they should offer food or rub corn syrup on the gums and seek immediate veterinary attention. For DKA, that requires intensive hospital treatment. 4V fluids to correct dehydration, specific types of insulin, like regular insulin, given carefully to lower blood sugar and ketones slowly to avoid brain swelling, electrolyte management, and treating any underlying trigger like infection or pancreatitis.
Okay. And the overall prognosis for diabetes?
Generally good. With appropriate insulin therapy, dietary management, diligent monitoring, and a committed owner, most diabetic dogs can live a good quality of life for many years. Prognosis for DKA is more guarded, especially if there's a severe concurrent illness. But many dogs do recover with prompt, aggressive treatment.
Good to know that management makes such a difference. Let's move on to hyperparathyroidism. This is less common, you said. Older dogs, too much PTH, high calcium.
That's right, uncommon, usually older dogs. The problem is excessive parathyroid hormone, PTH, leading to hypercalcemia, high blood calcium. The most common cause by far is primary hyperparathyroidism. This is usually due to a benign change hyperplasia or an adenoma, a benign tumor, in one or sometimes more of the 4 small parathyroid glands in the neck. This abnormal gland just produces PTH uncontrollably, ignoring the body's normal feedback signals. There seems to be a genetic predisposition in Cushing's. Rarely, maybe 5–10% of the time, it can be a malignant tumor, a parathyroid carcinoma.
Okay. And you mentioned secondary causes, too.
Yes, secondary hyperparathyroidism can happen, either nutritional, from a diet really low in calcium or vitamin D, or too high in phosphorus, or renal, due to chronic kidney disease. In CKD, the kidneys lose calcium, don't activate vitamin D properly, and retain phosphorus, all of which stimulates the parathyroid glands to work harder. But primary is the main focus when we talk about hyperparathyroidism as a distinct disease. The physiology is all about PTH's job, increasing blood calcium. It does this by pulling calcium from bone, increasing absorption from the intestines via vitamin D, and reducing loss from the kidneys. Too much PTH just cranks up blood calcium persistently.
And what signs does this cause? Is high calcium noticeable?
Often, it's not. Many cases are found incidentally on routine blood work when the dog seems perfectly fine. When signs do occur, they're usually mild and related to the high calcium's effects. The most common signs are polydipsia and polyuria, PUPD again. High calcium interferes with the kidney's ability to concentrate urine. Less commonly, you might see reduced appetite, lethargy, vomiting, weakness, or sometimes the formation of calcium-containing urinary tract stones, urolithiasis. Only in really severe, untreated cases might you see stupor or coma. Physical exam is usually unremarkable. Rarely, a large malignant tumor might be palpable in the neck. In the nutritional secondary form, you might see signs related to weak bones, like fractures.
So it's often found by accident. How is the diagnosis confirmed when high calcium is detected?
Diagnosis hinges on confirming that persistent hypercalcemia. After getting a detailed history and doing a full blood screen, including phosphorus levels, measuring serum ionized calcium is really important. That's the biologically active form. And it will be high in primary hyperparathyroidism or malignancy-associated hypercalcemia, whereas it's often normal or low in CKD, despite total calcium sometimes being high. The definitive diagnostic step is measuring parathyroid hormone, PTH,
concurrently with the ionized calcium from the same blood sample. In a normal dog with high calcium, the body should suppress PTH production, so PTH should be low. In a dog with primary hyperparathyroidism, the PTH level will be inappropriately normal or even high despite the high calcium. That confirms the diagnosis.
Ah, the feedback loop is broken. High calcium should mean low PTH, but doesn't.
Precisely. Imaging like a neck ultrasound is then usually done before treatment to try and identify which of the 4 parathyroid glands is enlarged or abnormal. Sometimes surgical exploration is needed if imaging isn't conclusive. X-rays or ultrasound are also used to check for those urinary stones.
And treatment.
The definitive treatment for primary hyperparathyroidism is surgical removal, parathyroidectomy, of the affected gland or glands. It's a delicate surgery because the glands are tiny and often stuck to the thyroid gland, and you want to preserve any remaining normal parathyroid tissue. Less common, less effective alternatives, sometimes tried, include ultrasound-guided ethanol or radiofrequency ablation of the gland. Medical treatment options to lower calcium exist, like bisphosphonates or calcitonin, but they aren't curative for primary disease and are usually used for short-term stabilization before surgery or if surgery isn't an option. For secondary hyperparathyroidism, nutritional or renal, management involves addressing the underlying cause, correcting the diet, managing kidney disease, possibly using phosphate binders or specific vitamin D analogs.
What about complications of the surgery?
The main potential complication is temporary postoperative hypocalcemia, low calcium. Because the abnormal gland was doing all the work, the remaining normal glands can become suppressed or lazy. After the abnormal one is removed, it can take days or weeks for the normal ones to wake up again. This post-op low calcium can cause muscle tremors, twitching, even seizures, and often requires hospitalization for 4-7 days for close monitoring and treatment with calcium and vitamin D supplements if needed.
Okay, so close monitoring after surgery is key. And the prognosis?
Generally excellent after successful surgery for a benign adenoma. Cure rates are high. There's a small chance of recurrence, maybe 5–10%, though higher in Cushing's. If left untreated, long-term hypercalcemia can cause damage through mineralization calcium deposits forming in organs. The kidneys are particularly vulnerable, potentially leading to irreversible kidney dysfunction or worsening CKD. Dehydration is also a risk.
Got it. Now, the flip side, hypoparathyroidism. Too little PTH, low calcium, less common, middle-aged females.
Correct, relatively uncommon. Insufficient PTH leads to hypocalcemia, low blood calcium, and often hyperphosphatemia, high blood phosphorus, more common in middle-aged female dogs. The cause is often unknown, idiopathic, but it's suspected to be immune-mediated destruction of the parathyroid glands, similar to Addison's or hypothyroidism, just affecting these tiny glands instead. We call it diffuse lymphocytic parathyroiditis. Other causes are possible, but less common. Iatrogenic, accidental damage or removal during thyroid surgery, a known risk. Destruction by neck tumors, maybe atrophy due to chronic hypercalcemia suppressing them, infectious causes like distemper, or rare congenital forms.
Okay, and the physiology is the opposite. Not enough. PTH means low calcium.
Exactly. PTH normally acts to increase calcium absorption from the gut, decrease elimination by the kidneys, and increase release from bones. Too little PTH reverses all that. Blood calcium drops, and blood phosphorus tends to rise, because PTH also helps kidneys excrete phosphorus. This chronic low calcium is the main problem, as it leads to increased neuromuscular excitability. Nerves and muscles become hyperexcitable, leading to tetany. The high phosphorus also impairs the activation of vitamin D.
So the signs are mostly related to nerves and muscles being overly sensitive.
Precisely. The clinical signs stem directly from the low blood calcium, and they can be intermittent, especially early on. Functional disturbances are largely due to that increased neuromuscular excitability. Owners might see muscle tremors or twitching, fasciculations, a stiff, stilted, or uncoordinated gait, ataxia, anxious or restless behavior, intense facial rubbing or pawing, seizures, general lethargy or weakness, increased panting, maybe loss of appetite.
It can progress from intermittent tremors to generalized muscle spasms, tetany, and convulsions. Chronic effects over time can include cataracts, maybe decreased mental function, bone density changes.
How do vets confirm this one, especially if a dog presents with seizures, which could have many causes?
Diagnosis relies on recognizing those characteristic clinical signs of neuromuscular excitability and combining them with the hallmark laboratory findings. We need blood tests. CBC, chemistry panel, focusing on calcium and phosphorus. Measuring ionized calcium is critical here. Again, it will be significantly low. Urinalysis is usually done too. The crucial confirmation comes from measuring parathyroid hormone, PTH levels. In a dog with hypocalcemia, PTH should normally be very high as the body tries to compensate. In hypoparathyroidism, the PTH level will be subnormal or undetectable despite the low calcium. This helps differentiate it from other causes of hypocalcemia like eclampsia, puerperal hypocalcemia, in nursing dogs where PTH is usually high and phosphorus is often low.
Okay, so low calcium plus low PTH equals hypoparathyroidism. And treatment, is it lifelong too?
Yes, it's a lifelong condition requiring continuous management. In an acute crisis, severe tetany or seizures, immediate treatment involves intravenous calcium gluconate given slowly and carefully to restore blood calcium levels. Rapid administration can be dangerous to the heart. For long-term maintenance, owners need to give oral calcium supplements like calcium carbonate or gluconate multiple times daily, and vitamin D supplementation, usually calcitriol, the active form. Vitamin D is essential to help the body absorb the oral calcium from the intestines. Doses need careful adjustment, especially initially, to find the right balance enough to control signs, but avoiding hypercalcemia, which can cause kidney damage or tissue mineralization. We gradually taper down to the lowest effective maintenance doses. Dietary changes might help aiming for high calcium, low phosphorus. Oral phosphate binders might be used if phosphorus levels are markedly high.
Sounds like it requires really dedicated owners for that long-term management.
It absolutely does, but the prognosis is generally excellent with appropriate treatment and conscientious monitoring. Dogs can maintain a very good quality of life.
That's great to hear. Okay, let's wrap up with our final disorder. Pheochromocytoma. This is a rare tumor of the adrenal medulla. Older dogs.
That's the one. A rare tumor originating from the chromaffin cells in the inner part of the adrenal gland, the medulla. Typically affects older dogs, average age around 11 years. It can occur in one or both adrenal glands. They are often functional, meaning they secrete excessive amounts of catecholamines, epinephrine, adrenaline, and norepinephrine, noradrenaline, those fight or flight hormones. This secretion can be continuous or episodic, paroxysmal, sometimes triggered by things like changes in blood flow, certain drugs, or even just direct pressure on the tumor. The normal negative feedback controls are lost. This leads to persistently high or sudden surges of catecholamines, causing potentially life-threatening effects like severe tachyarrhythmias, fast, irregular heartbeats due to beta-1 receptor overstimulation, and systemic hypertension, very high blood pressure due to alpha-1 receptor stimulation.
So like living in a constant state of fight or flight.
In some ways, yes, or having extreme surges of it. A major concern with these tumors is their tendency to be locally invasive. They have a high incidence, maybe 15–50%, of invading into the major vein nearby, the caudal vena cava, sometimes forming a tumor thrombus clot inside the vein. This can obstruct blood flow back to the heart, causing fluid buildup in the abdomen, aphthites, or hind limb swelling. They can also invade the nearby kidney. While often benign in terms of spread, metastasis only defines malignancy. That local invasion is very problematic. Malignancy means finding tumor cells spread to non-chromaffin tissues like liver, lymph nodes, or lungs.
And the clinical signs, are they dramatic?
Ironically, despite the potent hormones involved, the clinical signs are often vague, intermittent, and nonspecific. They frequently mimic other common disorders in older dogs like Cushing's, diabetes, liver disease, kidney disease. Signs are linked to those excess catecholamines and hypertension. Owners might report weakness, lethargy, episodes of collapse, anorexia, vomiting or diarrhea, panting, weight loss, anxiety, or restlessness. Sometimes PUPD, abdominal distension from the mass or ascites, hind limb edema, nosebleeds, epistaxis, or even seizures or acute blindness due to hypertensive damage. Non-functional tumors that don't secrete hormones can also cause signs just due to their size and pressing on things, but there can also be acute, life-threatening complications. Sudden congestive heart failure, pulmonary edema, fluid in lungs, heart attack, myocardial infarction, lethal arrhythmias, ventricular fibrillation, or cerebral hemorrhage stroke from the severe hypertension.
Wow, so it can range from vague signs to sudden catastrophe. Makes diagnosis sound really tough.
It is notoriously difficult, partly because many tumors might not secrete hormones constantly, and the signs are so nonspecific. Routine lab tests are often nonspecific. Maybe a mature neutrophilia, high neutrophils on the CBC. Chemistry might show subtle changes. Imaging is absolutely crucial. Abdominal ultrasound, especially with Doppler to assess blood flow, is key for identifying an adrenal mass and, importantly, looking for invasion or thrombus in the vena cava. Pheochromocytomas are often large, irregular, maybe heterogeneous in appearance.
So ultrasound is the main tool.
For initial detection and assessment, yes. A definitive diagnosis often requires histopathology on the removed tumor, or sometimes post-mortem. There are some specialized diagnostic aids, like testing urine for catecholamine metabolites, metanephrines, which can be supportive if elevated.
Okay, and treatment? Is surgery the only option?
Surgical removal, adrenalectomy, is the treatment of choice and the only method likely to reverse the clinical signs permanently. Medical therapy is used mainly for dogs where the tumor is non-resectable due to invasion or metastasis, or, critically, for pre-surgical stabilization. The goals are to control the dangerous hypertension and cardiac arrhythmias before attempting surgery. The most crucial part of pre-surgical management is using a drug called phenoxybenzamine. It's an alpha-adrenergic blocker. Giving this for 1–2 weeks before surgery is vital to help prevent life-threatening hypertensive crises that can happen when the tumor is handled during surgery and releases massive amounts of catecholamines. If surgery isn't possible, phenoxybenzamine might be used long-term to manage signs. So that pre-op medication is really key for survival.
Absolutely critical. Perioperative complications during surgery are common massive swings in blood pressure, both high and low, hypoxia, arrhythmias, cardiac arrest. The surgery itself is meticulous, especially if there's invasion into the vena cava requiring opening the vein venotomy to remove the thrombus. Post-operative hypotension, low blood pressure, is common and may require vasopressor support like norepinephrine.
Sounds like a very high-risk procedure. What's the prognosis?
Generally considered poor to guarded. However, certain factors improve the outlook. Positive prognostic factors include complete surgical resection of the tumor, absence of detectable metastasis, a tumor size less than 3 centimeters, absence of other major health problems, appropriate pretreatment with phenoxybenzamine, and limited or no invasion into surrounding structures like the vena cava. With complete reception and appropriate pretreatment, median survival times of around 15 months or more have been recorded. But the overall perioperative mortality rate, even with pretreatment, can still be significant, maybe 6–15% or higher, depending on the series and extent of disease.
Okay, a really challenging one. So wrapping this all up, what's the big takeaway for our listeners from this deep dive? Really seems to hammer home that the canine endocrine system is incredibly intricate. And these disorders truly are the great pretenders, as you said. It takes a really keen eye from owners noticing subtle changes and then advanced diagnostics from the vet. Recognizing just how non-specific many of these initial signs are. The PUPD, the lethargy, the skin changes, that seems critical. They can easily be brushed off as something else.
Absolutely, and I think this really underscores the vital role of that systematic diagnostic workup we talked about. You can't just stop at the first symptom. You have to dig deeper with specific lab tests, targeted imaging, and truly understanding the underlying physiology, what's actually going wrong with those hormones and glands. That's key for the vet, not just memorizing facts. But the really good news, and we've seen this with most of these conditions, is that with appropriate treatment, which is often lifelong, and that diligent monitoring and owner commitment, these dogs can lead good, comfortable lives. Modern veterinary medicine, partnered with dedicated owners, makes a huge difference.
Yeah, it really does. And hopefully for you listening, this gives you a deeper appreciation, not just for the science, but for your own dog's health and that partnership you have with your veterinarian. Your careful observations at home, noticing those small changes, can genuinely be the spark that starts a diagnostic journey and potentially saves a life or dramatically improves quality of life. So maybe tonight, as you look at your own dog, think about that complex inner world, that delicate hormonal balance, those hidden health challenges they might face. It all relies so much on our observation and the amazing diagnostic tools we have today. What other hidden aspects of your pet's health might you look at a little differently now, knowing just how much complexity can lie beneath the surface?